CAP protocol for reporting Phyllodes tumors of the breast. And then talk a little bit about common diagnostic dilemmas. And on core needle biopsy, I'll touch on the clinical behavior of fibroepithelial lesions, talking about the local recurrence and distant metastasis, with an update on the management, especially with margin and re-excision, and talk about molecular alterations and their possible diagnostic applications. Starting with the most common of fibroepithelial lesions, fibroadenoma. This is a circumscribed benign neoplasm of the terminal duct lobular unit that consists of a biphasic proliferation of epithelial and stromal component. This is the WHO classification definition. This is, as I said, the most, it's a very common tumor, probably the most common benign tumor of the breast for sure. It can occur at any age, but it's usually detected in younger women, although it can be detected also in a later age, especially because the stroma tends to become calcified. So sometimes a fibroadenoma in an older woman may be detected because of calcifications. There are at present no known predisposing factors for fibroadenomas, although there are some families where fibroadenomas are very frequent in multiple family members. So maybe there are some genetic alterations, predisposition we don't know about. The one exception is myxoid fibroadenoma. I'll touch on that. In terms of presentation, it presents as a palpable, painless mass, well-defined, rubbery to firm, mobile. And as I said, in older women, it may be detected because of calcification. The size is usually up to 3 centimeters, more or less, as a general, guideline. In terms of imaging, ultrasound is the best technique to appreciate a fibroadenoma as a well-circumscribed route to avoid hypoechoic and isoechogenic mass that has minimal to no posterior shadowing, which is a good sign, and generally has what is called a parallel orientation. It's oriented parallel to the overlying. The major axis is parallel to the overlying skin. Again, another benign sign. This is on the right, a picture of the cross section. I'm sure with this rubbery, nodular appearance, slightly lobulated, that I'm sure you're all familiar with. In terms of histology, it has a well-circumscribed border, not depicted here, but it's a balanced biphasic proliferation of glandular and stromal elements. The tumor is due to a proliferation, expansion of the stroma, of the specialized mammary stroma, of the terminal duct lobular unit, but, it grows together with the epithelial component and stretches it out, forming these characteristic structures. In general, the stromal cellularity is low in a fibroadenoma. There is no stromal nuclear atypia, and mitosis are extremely rare, I would say absent in most cases, with the, excuse me, with the possible exception of young or pregnant women, where we may find some mitotic activity even in the spindle cell of a fibroadenoma. I will mention right now that there are molecular alterations have been found in fibroadenomas that involve MED12 exon 2 mutations in about 60 to 80% of fibroadenomas. This is very a unique type of alteration that actually in solid tumors in humans occurs only in leiomyomas and sometimes also in leiomyosarcomas, but it's mostly in leiomyomas of the uterus. So you can see some parallel already there between these fibroadenoma in the breast and somewhat another spindle cell lesion that is hormone responsive in the uterus. Now, we always talk in general for fibroadenoma, but also in general for all fibroepithelial lesions. We distinguish between the intracanalicular and pericanalicular growth pattern. This on the left is the intracanalicular pattern with compression of the benign ductal elements by the expanded stroma that leads to the formation of these RC-form kind of slit-like epithelium-lined luminal spaces. On the right, the stroma grows more around the tubules, the glands, and the lumen remains patent. And this is described as pericanalicular pattern. Now, so far I've talked about usual or simple, or some people call it adult fibroadenoma on the right, but there are some morphologic variants of fibroadenoma that include myxoid, complex, and then juvenile and cellular. Myxoid fibroadenoma was first described by Carney in the context of Carney's syndrome. They identified, myxoid alteration of specialized mammary stroma in 21 patients, including one man, who had Carney's syndrome, as you know, is an autosomal dominant disorder due to inherited mutations of the gene that encodes the regulatory subunit 1A of protein kinase A. Myxoid fibroadenoma, they described it as a circumscribed but unencapsulated tumor that had normal and elongated acini embedded in a hypocellular, hypofibrillar, myxoid-looking stroma. And there was no stromal nuclear atypia. And they also mentioned in their paper that some myxoid fibroadenoma had cyst and sclerosing adenosis, so more complex features. I mentioned myxoid fibroadenoma, first of all, because it shouldn't be confused with, shouldn't scare people. It's a very hypocellular lesion. Typically, the vascularity becomes very prominent as all myxomatous type of tumors. But sometimes, the differential arises with a Phyllodes tumor that can have a very myxoid stroma. And in general, a Phyllodes tumor with myxoid stroma will be, first of all, in general, larger, and has more heterogeneous cellularity and increased cellularity compared to the very hypocellular look of a myxoid fibroadenoma, and will have at least focally some stromal atypia. The differential diagnosis may also include a very superficial look of a myxoid fibroadenoma that is has very bluish myxoid stroma, may mimic the mucin in a mucinous carcinoma. And this is more a problem if you have a small sample. There are papers from NYU where they reported it as a pitfall in the evaluation of breast FNA material, where the myxoid stroma of a myxoid fibroadenoma was interpreted as mucin. And the imaging doesn't help you because they both myxoid fibroadenoma and mucinous carcinoma will have similar imaging feature. But it's also a possible pitfall in the evaluation of a core needle biopsy material on a superficial look. One could think, well, this is a pool of mucin and these are neoplastic glands. Obviously not, and myoepithelial stains will resolve that if necessary. Another interesting thing about myxoid fibroadenomas is that we have done a little study looking at 11 cases, looking for the MET12 exon 2 mutations, and none of these cases had the mutation. So they, from a molecular standpoint, they didn't seem to classify with the usual fibroadenomas. We also found one case where the stromal component of the myxoid fibroadenoma had the same somatic inactivating mutation that is found in Carney's syndrome. So this could have been actually a myxoma. So I really wonder if these are truly fibroadenomas or myxomatous lesions that look like fibroadenomas because they are in the breast. Another entity is complex fibroadenoma that was defined by DuPont and colleagues in '94 as a fibroadenoma that had either one of the following features: sclerosing adenosis, papillary apocrine metaplasia, cyst formation, cyst greater, 3 millimeters or greater, and epithelial calcifications. And in their study of about 2,400 cases, they identified these features in nearly 23% of the cases. The real incidence frequency of complex fibroadenoma is really probably much lower. Two studies have found complex fibroadenoma in 16 to 15% of their cases. And complex features in a study from the Netherlands were identified in 40% of nearly 400 cases. So it's important to be aware of this, the possibility that complex features might be present in a fibroadenoma. And in particular, if some studies have found that complex fibroadenoma usually occurs in patients who are a bit older than the usual patients with usual fibroadenomas. And also the size tends to be smaller, nearly half the size of a usual fibroadenoma. And many times the complex fibroadenomas are detected due to the presence of associated calcifications. Now, the interest in complex fibroadenoma comes from the fact that when they were first described by DuPont and Page, they concluded their study saying that they had higher risk, relative risk of subsequent breast carcinoma of 3.1 compared to the 2.17 relative risk of fibroadenoma in general. And so actually some of our surgeons, when I first started my practice, including the chief of breast surgery, would say complex fibroadenoma, we need to excise. It has a high risk of finding breast carcinoma. So there was a lot of misconception. In reality, it seems that it's really not a complex fibroadenoma per se that is associated with an increased risk. But maybe the women with complex fibroadenoma have a higher propensity to have breast atypia elsewhere in epithelial atypia elsewhere in the breast. And this is a study from Mayo where 6% of women with a complex fibroadenoma had epithelial atypia somewhere in the breast, and not necessarily in the fibroadenoma, compared to only 1.6% of women with a simple fibroadenoma. And in their study, they also looked at the subsequent risk of breast carcinoma. They found that complex fibroadenoma is not an independent risk for breast cancer in multivariate analysis. Bottom line, from the point of view of our surgeons, we no longer excise complex fibroadenoma. And the other interesting thing is that MED12 exon 2 mutations in the stromal component of complex fibroadenoma are kind of rare. So either we misclassify these cases, or maybe complex fibroadenoma is yet another lesion that looks like a fibroadenoma in some ways, but it's not exactly a fibroadenoma. But it can create some issues in the differential diagnosis, again, mainly on core biopsy. We can simulate adenosis, a tubular adenoma, a papilloma, if it has a prominent papillary component, and even cases that are more nodular and where there is a mass and then a lot of sclerosing adenosis are, can simulate an invasive carcinoma, as indeed this case, the initial diagnosis was a complex, of invasive carcinoma, but the calponin, my epithelial stain will keep you out of trouble. Now, when we talk about fibroepithelial lesion, we always focus on the spindle cell component, but you can have also atypical epithelial proliferation involving fibroepithelial lesions. In fibroadenomas, we sometimes can find lobular neoplasia, in particular classic lobular neoplasia, ALH, classical CIS are not uncommon. In my experience, florid and pleomorphic are very uncommon in this setting. And again, just to say it incidentally, we do not excise at our institution a fibroadenoma in general. If we give a definitive diagnosis of fibroadenoma, they are no longer excised, at least at most centers in the United States. But that includes also a fibroadenoma that has classic lobular neoplasia. And I think there is a study from Ireland where they had about, I think, 20 cases, and only one yielded at excision a tiny 1.2 millimeter focus of invasive carcinoma. So excision in general is not recommended if there is a rad path concordance. But excision is always necessary if there is ADH or DCIS in a fibroadenoma. And of course, invasive carcinoma can also occur in a fibroadenoma, can be within the tumor, like this invasive lobular carcinoma, or adjacent to it. And I'm actually more concerned about these cases where there is a pre-existing mass, we know it's benign, and the tumor may arise next to it and grow and go undetected for some time. So, as I said also yesterday, in my opinion, all breast masses should be removed for for safety reason, but you know, nowadays the trend is not to excise a fibroadenoma. So this is a summary of what I told you so far. Fibroadenoma is benign, MED12 exon 2 mutations in 60 to 80% of cases. We spoke about the different morphologic variants, the differential diagnosis and pitfalls. Of course, I'm sure you noticed I didn't talk at all about juvenile fibroadenoma and cellular fibroadenoma. We'll touch on those two a little bit later after we discuss Phyllodes tumors. And Phyllodes tumors are sort of as rare as fibroadenomas are common. They represent 0.3 to 1% of all primary breast tumors and 2.5% of all fibroepithelial tumors. They occur in women. You know, there are many reports of Phyllodes tumor in men. Not many. There are a few reports in the literature, but I'm always suspicious about those cases. So in general, I would accept a Phyllodes tumor in a woman. In a man, I will wonder if it is a misdiagnosis of something else. In terms of age, they tend to occur at about 15 to 20 years later than fibroadenomas, around the age 40 to over 60 years. They are very rare and usually benign in women up to age 25, and extremely rare before menarche. And there are reports of rapid growth in women during pregnancy. All these suggest that there is an hormonal component that contributes to the growth of and the progression of to the growth of Phyllodes tumors. Although it has not been proven, there is definitely an influence of ER and progesterone stimulation on, and hormonal stimulation in general on these tumors. It typically presents as a firm and painless mass that sometimes there is a history also of a pre-existing mass with a rapid growth, a Phyllodes tumor that may have developed from a fibroadenoma. The size range is about 3 to 10 centimeters, but some cases can be very, very large. Predisposing factors, there are some predisposing factors for Phyllodes tumor. One is Li-Fraumeni syndrome. P53 germline mutation has been associated with a higher than expected rate of Phyllodes tumor. And, but that is actually not very much talked about. You know, patients with Li-Fraumeni have so many tumors. But here is a study of 550 patients that had Phyllodes tumor, and they had germline testing for other reasons sometimes. Only 2 of 21, there were 21 patients that were tested for P53, and 2 of these had P53 mutation, deleterious mutation. So 9.5% of these 21 patients had the Li-Fraumeni syndrome. So that is, as I said, you know, information that we don't have the full extent of. So this is there is a lot of interest in looking at the genetic alterations and the genetic predisposition of Phyllodes tumor. One thing that we know for sure is that Asian ethnicity predisposes to the development of Phyllodes tumor, not to you know, the largest series of Phyllodes tumor come from Southeast Asia, and there are studies from Australia where the population has either European or Asian origin, and the women of Asian ethnicity in Australia are more likely to develop Phyllodes tumor and have recurrences. Also, it's more a problem in women of Asian ethnicity because they tend to have a smaller size of the breast, so excision can be more complicated. Here is an example of the imaging of a Phyllodes tumor. There is, it's again rounded to oval, appears well circumscribed under ultrasound, is more solid. There is, it has a more heterogeneous, you know, quality, echogenicity, and may contain cystic spaces. And the major axis this time has a non-parallel orientation in relationship to the skin, which is a suspicious finding that you also find also in carcinomas. It's not unique to Phyllodes tumor. So, but you know, just when you read the radiology report, this may be a useful finding to interpret what the radiology thinks about these lesions, suspicious or not. Macroscopically, they're very large. In general, they have this word cut surface with these curved clefts that resemble the leaf buds. And of course, you all know that the word Phyllodes tumor comes from the Greek with Phyllodes meaning leaf, right? These images come from the WHO book, and this is the WHO definition. Phyllodes tumor is a generally circumscribed fibroepithelial neoplasm that shows a prominent intracanalicular architectural pattern with these leaf-like fronts that are capped by luminal and epithelial and myoepithelial cell layers with stromal hypercellularity. Again, it's the specialized mammary stroma of the TDLU that grows exuberantly and produces these configurations. Now, how do we classify Phyllodes tumors? Well, we classify them based on different morphologic features. And these include the tumor border, stromal cellularity, stromal atypia, mitotic activity, stromal overgrowth, and then the presence of malignant heterologous elements. So we'll go through all these one by one. The tumor border in a benign Phyllodes tumor, we use these features to classify the tumors in 3 subgroups of benign, borderline, and malignant. So in the tumor border in benign Phyllodes tumor is well defined. In malignant is diffusely permeative, and in a borderline is well defined, but maybe focally permeative. This is the definition by the WHO. As I mentioned in just a few months ago, the CAP, the College of American Pathologists, has released a protocol for reporting of Phyllodes tumor that in the United States now we have to comply with, but I think provides useful information. And this is their definition of circumscribed. They call, the benign, well-defined, they call it circumscribed with a very smooth and well-defined margin and shows minimal irregular interface with the adjacent stroma. I don't know if you notice here, there are some adipocytes embedded in the tumor. So this is minimal infiltration, very, very focal. And this is more focally infiltrative, margin with unequivocal invasion into the adjacent stroma in one low power field, and extensively infiltrative as shown before. Stromal cellularity, of course, we all know what's marked, very confluent areas of densely overlapping nuclei, but, the mild cellularity is very inconspicuous overall. There is a slight increase in the stromal cells with evenly spaced nuclei that are still not touching or overlapping. And I think it's useful to use as a reference point the cellularity of the normal adjacent terminal duct lobular units, and there should be at least twice the cellularity that you see in the normal mammary stroma. And then moderate will fall in between. These images and definitions come from a consensus review paper that was published a few years ago and you can access online. This is a stromal atypia. It ranges again from mild to marked. Marked we all agree on. The mild, then the nuclei have little variation in size, but the nuclear contour is still smooth, and notice they're still not touching, not overlapping with one another. So it's a very subtle change and not always, everybody agrees on this. Again, it helps to compare with the nuclear features with the adjacent normal mammary, specialized mammary stroma in the normal terminal duct lobular units. And in general, in my practice, I always say, look at the normal first. So I have a reference point for that specific case. And it makes it easier to compare the normal that I know is normal and make a more definitive assessment on what is abnormal. And then, of course, moderate cellularity falls in between. Mitotic activity, as alluded yesterday, is also for invasive carcinoma, is much more reproducible in a way, because we can count the number of mitoses. In benign phyllodes tumor, they're usually few, meaning less than 5 in 10 high power fields, or if you use square millimeters, like it's recommended, we all switch to reporting mitotic activity per square millimeters in, getting ready for the future of digital pathology. Then you're supposed to have less than 2.5 mitoses per square millimeter. In malignant, more than 10 or more per 10 high power fields, or more than 5 or more per square millimeter, borderline falling between 5 to 9 in 10 high power fields, so 2 to less than 5 per square millimeter. How do we count mitosis? That's a question I get very often. So the guidelines is that you start by looking around, identifying the more cellular area, and you start looking at areas that seem to be mitotically active and focus on that. And by avoiding, of course, areas with biopsy site changes or areas at the periphery of necrosis where cytokines may be produced that simulate mitotic activity. And then in these more cellular, apparently more mitotically active areas, we identify the first stromal mitosis, that's the index mitosis, and we start then counting randomly 10 high power fields in that same area. I personally tend to count in multiple, in phyllodes tumors, many times they are large tumors, and we get a lot of slides. So I will do that, I'm not saying in every slide, but almost in every slide. And I mark on the slide the number of mitoses, so that then I have an idea about, the mitotic activity. And sometimes I even report the mitotic activity is highest in this slide, just for future reference. But these are the guidelines on how to count mitosis. And then the last parameter that we are, of the 5 that we have to evaluate and report and use for the grading of phyllodes tumor is stromal overgrowth. That is never present in a benign phyllodes tumor, may be present, often present in malignant phyllodes. It's defined as absent or very focal in a borderline. Now, very focal is a bit vague. It's unclear what it means. It's one focus, 2 foci, how much should it be? But in any case, stromal overgrowth is defined as the lack of any epithelial component in a final 40x field of view, which means at 10x lens in your eyepiece and at 4x objective. And this corresponds to an area that is 22.9 square millimeters. But of course, if you have a different, there are ways to calculate the area in your high power field, in your microscopes, and you should use that. But again, this is the most, from a biology point of view, this was the most significant finding in phyllodes tumor that developed distant metastasis back in a study done, I would say, 30 years ago. So is it still true today? Well, indeed it is. This is a study on 67 patients with phyllodes tumor. 15 were borderline, 52 classified as malignant. 18 of these tumors had stromal overgrowth. They were followed for a median of 10 years. 15 patients, 22% of all group, developed distant mets and died of disease. And of these 15 patients, 11 came from, that is 61% of the 50 patients who died, came from the group of patients that had phyllodes tumors with stromal overgrowth, and only 4 came from the group of patients without stromal overgrowth. And the 5-year cancer-specific survival for patients with stromal overgrowth was only 32%, 32.2. For patients with phyllodes tumor without stromal overgrowth was 97.7%. So they lived much longer without problems if there was no stromal overgrowth. So this is a very powerful indicator of the aggressive behavior of a phyllodes tumor. And not surprisingly, basically indicates almost the beginning of, sarcomatous growth of the stromal component. And the hazard ratio of a Phyllodes tumor with stromal overgrowth was 22.52-fold higher than for Phyllodes tumor without stromal overgrowth. So a very powerful indicator of stromal overgrowth. And recently I'm a bit a compulsive pathologist, but I've started also to mark on the slides, how many fields of stromal overgrowth I see. There is one, or there is none, or there is two. And in the end, I think we should have a better assessment of this stromal overgrowth, because there is quite a range between just one focus or two, or, 10 foci of stromal overgrowth. We'll see another case that I will present later where it gives the point. And then there is this component of malignant heterologous elements. These are always absent in a benign Phyllodes, absent in a borderline, may be present in a malignant Phyllodes tumor. So you're all familiar with, it's basically the stromal cells acquire a morphology that is suggestive of an osteosarc, or chondrosarc, a liposarc, and this can occur alone or in combination, and many different combinations are possible. And in two studies, their frequency was, the frequency of malignant heterologous elements was about 20% of the cases of malignant Phyllodes tumor had these heterologous elements. Now, I highlighted the liposarcoma because our thinking about liposarcomatous component in a Phyllodes tumor has changed substantially, because some studies that have done microdissection of those liposarcomatous areas in malignant Phyllodes tumor or immunohistochemistry have found that none of the genes or molecules that are typically found in liposarcomas is expressed in these tumors. So they look like liposarcomas. Actually, they have perfect lipoblasts, right? But they're not true liposarcomas and don't behave like that. So if liposarcomatous change is the only change that the only heterologous element that you find in a Phyllodes tumor, that's not longer enough to call it a malignant Phyllodes tumor. And this is the statement by the WHO that a lipomatous component alone does not warrant diagnosis of malignant Phyllodes in the absence of other morphologically malignant features. For example, this case from our institution was initially called many years ago malignant Phyllodes tumor. We look at it today. This is the girl's photo. Here is the histology. It's all looking very bland fat, but clearly with a spin, a nodular mass with the elongated ducts. This is not a malignant Phyllodes tumor according to the WHO today. And that is an important point. You need to have high-grade cellularity, high mitotic activity, marked nuclear atypia, all that to give a diagnosis of malignant Phyllodes tumor. So putting all these characteristics together, the most common type of Phyllodes tumor will be benign, 60 to 75% of cases. The least common are malignant, 8 to 20%, and then there are some borderline cases. The CAP protocol has pointed out to the fact that people sometimes give it just a diagnosis, oh, this is a borderline Phyllodes tumor, but don't specify how they reached this diagnosis. So it requires now that, at least in the States, we report all these various features that are listed here, the tumor size, the type, the final classification, but also the stromal cellularity, mild, moderate, marked, the atypia, the stromal overgrowth, mitotic rate, all these features need to be included in the report, including the margin status. And they have really restricted and clearly stated that the diagnosis of malignant Phyllodes tumor requires all these 5 elements I described to you before, basically the marked stromal cellularity, marked stromal atypia, stromal overgrowth, 10 or more mitosis in 10 apparel field and this permeative tumor border, or you have malignant heterologous elements. Those are enough to give the diagnosis of malignant phyllodes as long they're not liposarcoma-like areas by themselves, they're not enough. So this is much more restrictive. Before we were like, oh, there is a high cellularity, the mitosis, there is 9, but it looks malignant, and some people would call it malignant. Now we have a more strict criteria for the diagnosis of malignant. It needs to have all these features. Of course, they are by default, if it doesn't have all these features, then it will be classified as a borderline. What about the clinical behavior of phyllodes tumor? Well, the clinical behavior includes the ability to recur locally, the ability to progress, to become, you know, the concern that this may progress in the local recurrence and have a higher grade, and the ability to develop distant metastasis. And I'm going to use the largest series of 605 phyllodes tumor treated and diagnosed and treated at the Singapore General Hospital in Southeast Asia. That just to illustrate the point, other series have been published, but this is very substantial. And so here there is a large series of 605 phyllodes tumor. The patient median age was 43 years. The majority were benign, 440, 111 borderline, and 54 malignant. When they looked at the recurrence rate, overall was 12%, but actually there was a increase in the local recurrence rate significantly associated with the grade of the phyllodes tumor. And of course, the borderline and the malignant had a higher local recurrence rate. Then we look at the grade of the recurrence. We start with the benign phyllodes tumor, only 11% recurrence rate. They basically all recurred with the same grade, except for 21 cases, where some cases recurred at the borderline and only 4, less than 1%, as malignant. So the grade progression was overall 4.8% in this series. The borderline phyllodes tumor, they had a local recurrence of 14.4%. Most of them had no progression. Only 1.8% demonstrated the grade progression. It's 2 out of these 111 cases, 1.8%. Is, you know, a fairly low rate. And of course, the malignant don't progress. They will recur as the same. Some cases, though, had a lower rate of recurrence. So overall, if we look at this data, it's really not that common that we have a benign recurring as a malignant. And I think it's important actually to sample extensively this tumor at first presentation to identify suspicious areas that, you know, and classify the tumor properly at initial diagnosis. I want to point out also to some features that were found. This is a recent study of, you know, in a group of 52 phyllodes tumor that had local recurrence. They identified different features. They had a few cases, but I wanted to point out to this myxoid fibroadenoma-like morphology in 5 cases. And these 5 cases were phyllodes tumor that recurred. One phyllodes recurred 3 times. And the initial grade at first diagnosis was benign phyllodes or borderline. You can see that the primary tumor looked very, 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 very bland with very low cellularity. And it also still had a relatively low cellularity and low cytologic atypia, even in the recurrence. So, but this feature, the myxoid stroma, I found, and I'm going to show you a case that is also associated with frequent recurrences. And so I think we have to identify these phyllodes tumor that have a more myxoid looking stroma. They still show peripheral infiltration, stromal increased cellularity, there is intratumor heterogeneity. They may show nuclear atypia, although in a myxomatous type of lesion, nuclear atypia can be harder to identify in general. And there is another study from Canada where tumors that had more than 50% myxoid stroma had a higher rate of local recurrence, but not of distant metastasis in their study. So there may be something, of interest to study in these cases. In terms of benign, so we want to prevent a local recurrence. And to prevent a local recurrence, most of the time people say, okay, we have to re-excise, get clean margins. But is it always necessary? In the past, the traditional say was all phyllodes tumor need to be excised with a 1 centimeter wide margin all around, regardless of grade. But there is now evidence that maybe that does not apply necessarily to benign phyllodes tumor. These are series that have looked at the local recurrence of benign phyllodes tumor, and overall the local recurrence was around 4%. And if we look at the grade of the local recurrence of benign phyllodes tumor in this group of patients, the majority recurred just with the same morphology, and some with a higher grade borderline morphology. There were, out of nearly 1,000 cases, only 2 that developed higher grade morphology and recurred as malignant. And some of these cases had in retrospect, some borderline features like heterologous elements that had not been initially, identified or recognized. That's what the investigators say in their discussion of the paper. But if we look at the margin status, it looks like the margin does not relate to local recurrence, and is not predictive whether it's positive or close. There is a general, all these studies really found that the margin did not really matter in this, did not correlate with the local recurrence of phyllodes tumor. So in this contemporary series, the local recurrence of benign phyllodes is up to 5% or less. The rate of grade progression is extremely low. The chances of having a benign that will recur as a malignant is extremely uncommon if you do a good sampling and a good classification initially. And the margin width does not seem to affect the local recurrence rate. So as I try to emphasize once again, it's important to accurately grade the phyllodes tumor, evaluate all the parameters I just discussed, and do a thorough sampling, focusing on the more solid and fleshier area, and also the tumor periphery. But based on this new evidence, the management of benign phyllodes tumors, at least in the States, has changed. And these are the National Comprehensive Cancer Network, the so-called NCCN guidelines, that are being used for managing patients with breast cancer and also with phyllodes tumor. And it is recommended that after a diagnosis of benign phyllodes tumor, the patient be followed for 3 years, and there is no recommendation to re-excise the margins. And they state clearly that excisional biopsy includes complete mass removal, but without the intent of obtaining surgical margins. However, the CAP guidelines still recommend the reporting status of benign phyllodes, the margin status of the benign phyllodes tumor. For the borderline and malignant phyllodes tumor is a completely different story. The local recurrence rate ranges between 20%, and they need to be re-excised. And the grade progression of borderline phyllodes, I'm not going to show you all the data, but is also relatively low for borderline to malignant phyllodes. But still, there is a risk that is much greater, so re-excision of the margin should be done. In terms of distant metastasis, this is another series, the same series from the Singapore group. They look at the local recurrence rate and distant metastasis. The events are very rare. Distant metastasis for phyllodes tumor are not that common. but they clustered only with malignant phyllodes tumor. So it appears that it's really the malignant phyllodes tumor, maybe the malignant phyllodes with a lot of stromal overgrowth that will eventually metastasize. So it's not clear what drives this metastatic potential, but definitely it's the malignant we have to be careful with and diagnose correctly. And because they have a substantially, more aggressive clinical behavior, so much that malignant phyllodes carry the metastasis and death rate of 22%. In addition, size in another study also from Singapore, the size greater than 9 centimeter and the presence of malignant heterologous elements, not the lipomatous component, were significantly associated with reduced metastasis-free survival by multivariate analysis. And these are the NCCN guidelines for borderline and malignant phyllodes, wide excision with at least, recommended 1 centimeter or greater margin, and then you follow the patients. There is no prospective randomized data that supports the use of radiotherapy for primary treatment of phyllodes tumor, including malignant phyllodes tumor. And in general, there is no adjuvant chemo that is given in the primary setting. And just to, I realize can I go on? There are molecular alterations I'll touch briefly on for phyllodes tumor. These include, these MET12 exon 2 somatic mutations are found in all type of fibroepithelial lesions, although with the lower frequency in other cases. Here is in fibroadenoma, were first identified in fibroadenoma, then in phyllodes as well. And they are quite characteristic in a certain spot. So they can be used even to support the fibroepithelial origin of these. Of course, in malignant phyllodes and in borderline, we find additional alterations. And in particular, our group has found the third promoter mutations, more uncommonly amplifications, that tend to increase in frequency. You see this orange bar where, in this diagram, we have every case, every column is a case, every row is a gene, third is represented here. You see an increasing frequency of third promoter mutation, rare in benign phyllodes, and but increasing in malignant phyllodes tumor. It does correlate with a more aggressive behavior, and malignant had it in nearly 70% of the cases. We found no third alteration in fibroadenoma. Some other groups have found them. There are also other genes that are involved. Why do I mention these alterations? Because actually, you all, I'm sure, have encountered situations where there is a high-grade spindle cell neoplasm, and the clinician wants to know, is it a malignant phyllodes tumor or a metaplastic spindle cell carcinoma? For metaplastic, there is a whole different treatment pathway with, chemotherapy, radiotherapy. For malignant phyllodes, even though they can be aggressive, there is no chemo, no radiation therapy. So it's important to give, to sort that out. And here is an example of a case where, we couldn't come up with a definitive diagnosis. Some features suggested the possibility of a fibroepithelial tumor, the presence of few entrapped elongated ducts, but there was nowhere the definitive evidence. So I signed it out as favor malignant phyllodes, but cannot rule out heterologous, a metaplastic with heterologous elements. There were also some rhabdoid-looking areas. And I suggested to the outside pathologist to do molecular testing, and he sent me an email later on saying that he had sent a case to a company for molecular testing. We cannot test outside material. And they did not find any reportable alteration, but they found this MET12 G44D substitution that is exactly one of the alterations characteristic of, part of the alterations of MET12 exon 2 we find in fibroepithelial lesion. So in the appropriate clinical, radiologic, histologic setting, if you find this mutation, that is diagnostic, supports a malignant phyllodes tumor in this case, which raises another question. Can, malignant phyllodes tumor develop from a fibroadenoma? Indeed, they could. It's an extremely rare event. So this doesn't change our management of fibroadenomas, but there is definitely a progression from the possibility of a rare case progressing from fibroadenoma to malignant phyllodes. This is a summary of what I just told you about all these lesions, and I'm not going to discuss it in detail. I want to touch very briefly on these diagnostic dilemmas that we encounter. Is it a fibroadenoma, benign phyllodes, or a cellular or juvenile fibroadenoma? And then on the other hand, the differential diagnosis of malignant with other spindle cell lesions. It's always a problem. We don't have enough time for all this. I just want to give you the definition of cellular fibroadenoma according to the WHO. It's supposed to have a more pericanalicular pattern without any real condensation of the spindle cells around the duct. And it has mildly to moderately increased stromal cellularity, less than 1 mitosis per square millimeter, which is less than 2 in 10 high power field. You are not supposed to have any nuclear atypia, right? So no mild nuclear atypia, which can be a difficult thing to assess. Shouldn't have any exaggerated intracanalicular architecture or periductal condensation and intratumoral heterogeneity. These are very difficult features to assess, especially in limited material. And really, if you find stromal heterogeneity, this will favor benign phyllodes tumor. But in general, it's a very difficult differential diagnosis. And here is an example of squamous metaplasia away from the core biopsy site may also help. It's more common in a phyllodes, is found in phyllodes tumor, not really in fibroadenomas. But the differential diagnosis is quite challenging. Here is a juvenile fibroadenoma, most common in adolescent girls or young women, can be very large. And this is defined by the WHO as having a more pericanalicular growth pattern again. So pericanalicular pattern in a sense is a good sign. If you find a predominant rounded arrangement of the glands, that is a good feature that favors a less aggressive lesion. And it has a uniform, mild to moderate increase in stromal cellularity. And this fascicular growth pattern is quite common. There is no substantial nuclear atypia. Stromal mitosis, again, very low, less than 2 per 10 high power fields. UDH, usually most commonly of the gynecomastoid type, can be present. This is a study we did from our institution and a study from Singapore comparing looking at the features of fibroepithelial lesion in women under age, up to age 18. We found that the majority of them had fibroadenomas, and the majority of the fibroadenomas were juvenile fibroadenomas. The mitotic activity was less than 2. In one of these cases was skewed a little bit because this young woman actually had just been pregnant, so maybe she had many more hormones than normal circulating. So this 7 mitosis per 10 high power field was her case and kind of skews the mitotic rate. The border was always confined. The growth pattern was pericanalicular in 23 out of 24 cases, and epithelial hyperplasia was present in 7 cases. The group at Singapore has also looked at MET12 exon 2 in mutations in this group of lesions. They found them in 1 out of 2 usual fibroadenomas, but also in 35%, only in 35% of the juvenile. That suggests that maybe they're not even fibroepithelial lesion, typical fibroepithelial lesion. We'll see where that leads. And then just a few comments in terms of the core needle biopsy diagnosis. Many features have been investigated by many different groups. One feature that is important, age, patient age. If the patient is 50 years or older, is more likely to have a phyllodes tumor. And then fragmentation of the cores that reflects this frond-like arrangement, increased stromal cellularity, heterogeneous stromal cellularity, nuclear pleomorphism, no epithelium in at least 100x field of view, which would be the core biopsy correlate of stromal regrowth. I honestly, I'm not too convinced of that, but that's how it's reported. And then mitotic activity and finding adipocytes are mixed with the stroma, the infiltrative margins. The group from Mayo has reported that if you find 3 or more mitosis in 10 power field, that is diagnostic of phyllodes tumor. I use that criterion a lot. And then they also state that if you have 3 or more of the histologic features listed here, highlighted here, that is also diagnostic of phyllodes tumor. And here is a core needle biopsy that is quite diagnostic of phyllodes tumor. There is a nice cleft, increased stromal cellularity, peripheral infiltration, in between benign adipocytes, mitotic activity. And this was, we diagnosed this as at least borderline on a core. The excision had a malignant phyllodes. There are some cases where the stromal cellularity is increased. There is not even, more a typical growth. Could this be PASH? We thought this was a fibroepithelial lesion with increased stromal cellularity. And, what to do with these cases? In reality, there is no way to classify them definitively between fibroadenoma or benign phyllodes tumor. A case like this, it also depends on the sampling that the radiologist has given us. And, that was the core biopsy of this case. It didn't have much of the feature of a phyllodes tumor, but, the imaging indicated that there was more of a large mass, and at excision turned out to be a benign phyllodes. And so these are statements that in difficult cases, it may not be possible to distinguish between fibroadenoma and phyllodes, benign phyllodes. And the core biopsy diagnosis of benign fibroepithelial lesion may be appropriate pending excision and complete histologic assessment. So I added this. This is not definitively in the NCCN guidelines, but I put it here in italics, that for fibroadenoma, no excision is required. For benign phyllodes tumor, excision is required if diagnosed in a core needle biopsy. But there are these cases where we can't commit. And if we are concerned about, it could be a benign phyllodes tumor, so far it should be taken out. And then decide based on the, more extensive examination of the entire specimen and decide whether it's a fibroadenoma or a benign phyllodes. But the management actually doesn't change between the two, because so we are going towards, in the future probably we'll manage benign phyllodes and fibroadenoma as a whole, and then the high grade malignant and borderline more like a different group of lesions. So I thank you very much for your attention.